All righty. So we'll talk about anticoagulants. I'm recording. Do I need to stop it for a minute? Does anybody have any off the record questions we need to ask or anything like that? However, I am an open book, so everybody's ready. Professor Padilla will be joining us in a few moments. She had some unexpected traffic issues. As we all know, they're very, um, uh, they're, Austin is not a stranger to traffic problems, so she'll jump on in a minute for sure. So, so we'll get started. We're going to be talking about antiplatelets, anticoagulants, thrombolytics, and the like. Okay, so what what does an antiplatelet do? What does an antiplatelet do? What is an antiplatelet? What's an example? That's right. Stop the clumping. Just say no to clumping. Just say no to clumping. They actually they don't thin the blood so much as they prevent platelet aggregation. So they decrease the ability to clot by preventing platelet aggregation. So what are some examples? Plavix, absolutely. What's something like over the counter, like get in a minute? What is that? Aspirin, absolutely, aspirin. So what's an anticoagulant? What's the difference? What's an anticoagulant? Well, it actually stops the clotting cascade. So an anticoagulant decreases the ability for the blood to clot, right, by stopping proteins known as clotting factors. So they basically stop the clotting cascade. Clotting has a lot of factors that determine its ability. You have a clotting cascade. If you will remember that from A&P, right? Does anybody recall that information from A&P? Well, anyway, intrinsic and extrinsic, absolutely on spot, on spot. So then, what is a thrombolytic? What is thrombolysis? What is that? What's the difference between that and an anticoagulant? What's a thrombolytic? Absolutely, absolutely. It breaks up or dissolves existing clots. So when is it absolutely, Michelle, Heather? So Alice, absolutely. Um, so dissolves clots, yes, Martura. Um, so when can you think of a couple of times when you would expect to give your patient a thrombolytic? What's a couple of times? Maybe so, maybe DVTs for sure. After an MI, absolutely, absolutely, and also TIA could be absolutely, and also a stroke, right? Because there's two types of strokes. Absolutely, very good. Metro and Heather, very good. So you can have, but you don't want to give it for a specific kind of. If you have an embolic stroke, yes, but certainly you wouldn't want to give it for a hemorrhagic stroke, right? Absolutely. Very good. Very good. So that's just kind of a little backup or, starting place. I know Professor Padilla has joined us. Professor Padilla, do you have anything you'd like to share at the beginning of the class? Um, any experiences or information you'd like to share to springboard us on this road? Well, she will jump in a minute. She will jump in a minute. So we'll be talking about Coumadin warfarin, right? So you'll have the experiences of giving this particular drug many, many, many times in your career. It's given a lot. It's given. What are a couple of reasons why you would give Coumadin, especially to the elderly population? Why can you think you'd give Coumadin to the elderly population? AFib, absolutely, absolutely. Now it could prevent, hopefully it could prevent PE, but Coumadin, if somebody has a PE, you're not going to give Coumadin. Why? Why would you not give Coumadin in a PE? Any ideas? Well, and a lot of these things, um, a lot of these things, you have to, uh, a PE is a very emergent situation. So you're going to need something that's going to bust that clot really quickly. And we're going to talk about a couple of drugs called urokinase and streptokinase. And so a PE, and my mom had a PE. And so I've only seen two in my life. And when you see them, you can't unsee certain things. So, for instance, a PE, what happens is there'll be a line of demarcation on your patient's abdomen, and at the spot of the clot, from the clot up on the patient's chest, it will be blue. It's the most profound thing I've ever seen. And once again, you can't unsee stuff like that. So anyway, we talked about uh, warfarin Coumadin. It's called a blood thinner, but it really doesn't thin your blood. It affects the constituent components of your blood in a specific way. Um, they are actually vitamin K antagonists. So, what is a vitamin K antagonist? What does that mean for Coumadin, that it's a vitamin K antagonist? What's a really good clue about Coumadin and vitamin K? Antidote. Absolutely. Absolutely. Absolutely is a vitamin K inhibitor. Absolutely antagonist, same thing. Which is why it's used to reduce stroke risk, certainly with AFib. Because you know what AFib is? AFib is the atria just quivering. And, it quivers and it doesn't empty completely. And in the apices of the atria, the top parts of the atria, blood can pool and then they can clot. So that's how AFib can affect the clotting mechanism for sure. So warfarin or super warfarin, they're vitamin K antagonist. They primarily act through the inhibition of 2,3 reductase. Of course, it has to do with all the clotting factors, 2, 7, 9, and 10, and which of course won't be on your exam, I can promise. But and if you dive off deeper into um, your critical care course, there'll be other information that will pertain to clotting, and certainly um, uh, critical care bedside uh, care, nursing care. Um, so assume it safe to believe that Coumadin or warfarin, they're used interchangeably, um, can be reversed by vitamin K because vitamin K is an antagonist. So what is Xarelto? Uh, rivaroxaban. There you go. How's that? It also inhibits the factor 10 um, mechanism of clotting. Um, let's see. Okay, somebody joined. Welcome. It does not inhibit thrombin, so it doesn't affect platelets. So if something affects thrombin or inhibits thrombin, which means it activates factor 2, which is just a side note, but if it affects the thrombin, then it's not has no effects on the platelets. So Xarelto, um, it's a non-vitamin K it's a non-vitamin K antagonist anticoagulant. It causes less brain bleeds than Coumadin, which is great. Another thing about Coumadin versus other alternatives to clotting is that you don't have to monitor Coumadin. You have to do frequent monitoring of the INR, and there's a window of therapeutic range for INR for your patients that are taking Coumadin. Does anybody know what that is? Does anybody know what the window is? Absolutely, 2 to 3 in their INR. Perfect, perfect. So if it's below that, what does that mean? If it's below 2, what is that actually saying? There's not enough, right? And so it's clotting too quickly, right? So if it's above 3, it's not stopping enough, correct? So anywho, we'll talk about that more too. So there's another one called Pradaxa. There's Eliquis. Um, and certainly all of these can be used for AFib. They can also be used if your patient is in the hospital, they can be used as prophylactic treatment for what? DVTs, absolutely. You have a patient that's lying around in the hospital, they're not moving a lot, say they had surgery, they're not able to ambulate and keep their blood flowing correctly. Then, of course, they may be on one of these low molecular weight heparins. Um, uh, Pradaxa reversibly binds to the active site on the thrombin molecule. And of course, this is information you don't know, you don't need to know, but just suffice it to say that these are low molecular weight alternatives. Um, Lovenox is something that you'll see given subcutaneous a lot. It contains a low molecular weight heparin. It binds and accelerates the activity of antithrombin 3. Okay. It um, varying, it's usually weight based or varying the dose, and so you can vary the dose to reduce the excess bleeding opportunity. And so this is what you'll see. A lot of patients will go home from the hospital on Lovenox. A lot of patients will be given this in the ICU. A lot of critical care patients receive Lovenox as well. And so that brings us to aspirin. It's an antiplatelet, prevents blood cells, platelets really, from clumping. Oh, Paige, you had a PE in July and they gave you Lovenox, then started me on Eliquis. Wow, that had to be scary. Goodness gracious. How did that happen? Wow, I'm so sorry. Huh. Wow. It was it this July? Wait a minute, last July, the 21? Oh, wow. It wasn't vaccine related, was it? Vaccines have been known to cause hypercoagulation. Just saying, asking. I'm so sorry. Yikes. Um, so, yeah, yeah, particularly in females. Um, so antiplatelet drugs prevent platelets from clumping. Um, and one thing about aspirin is all of these anticoagulants can cause bleeding, even aspirin. So patient teaching, what would patient teaching be about around these anticoagulants? Check for bleeding. Check your stools, no razors, absolutely no razors. Report any bleeding for sure. Monitor for bruising, gums, bleeding gums, soft toothbrush, um, tarry stools, petechiae, dental procedures, absolutely, absolutely. Coffee ground vomit, very good. Man, you guys are on top of this for sure. So let's see, Plavix is a class of drugs, of course, that inhibit platelet production. Um, no, the generic name is clopidogrel, can't pronounce these words today. Clopidogrel. I've been in meetings all day talking a lot, if you can tell. And so now is where we talk about the two other drugs. Ataplase is a thrombolytic medication. It is used to treat acute ST elevation myocardial infarction. So if your patient comes in and they have ST elevation and chest pain, they're probably going to get Actiplays in a very based, certainly after their EKG, but they'll get it really quickly. Urokinase, there's urokinase and there's streptokinase. Urokinase is an enzyme made in the kidney, and it's found in the liver, of course. It's a thrombolytic as well, sometimes called clot busters. It helps your body produce a substance that dissolves unwanted blood clots. It can be used, of course, to treat clots in the lung, and it can also be used for purposes. It has some off-label purposes as well. Streptokinase, it was associated with the slowest rate of clot lysis. So urokinase is something that you would get certainly for a PE. Okay. Other uses for streptokinase, of course, can be MI. It's actually just associated with an intermediate rate of lysis, but it appears to be the agent with the greatest degree of fibrolytic specificity versus streptokinase. Urokinase is. So if your patient is experiencing a PE, you can well imagine that you'll give them urokinase. Alrighty, so what's the difference between antiplatelet and anticoagulant? We talked about them. One is for platelet aggregation, and the other is for coagulation prevention, right? Antiplatelets stop blood cells from sticking together and forming a clot, right? So they're just anti-platelet clumping. Let's see. Common adverse effects of antiplatelet medication: headache, for sure, dizziness, nausea, indigestion, diarrhea, constipation. Of course, diarrhea and constipation can be a side effect of every drug we talked about. Abdominal pain is one of the hallmarks of adverse reactions of these antiplatelets. Nosebleeds, of course, any bleeding, prolonged bleeding time. Someone has a nosebleed that just won't stop. And like somebody mentioned earlier, easy bruising as well. What are contraindications for using antiplatelet medications? Anybody know? What would be contraindications? Recent surgeries. Yep, absolutely. Peripheral vascular disease. I think that's probably what you meant to say. Yes, esophageal varices, anything that could, a recent stroke, intracranial thrombocytopenia, absolutely. Significant thrombocytopenia, recent intracranial hemorrhage, certainly hemorrhagic stroke for sure. Known bleeding disorder, absolutely, very good, very good. Complications of antiplatelet medications, we talked about that. What labs you use for taking antiplatelet medications? Of course, clotting time. You can definitely do clotting times, PT, PTT, INR, absolutely. And make sure you're familiar with those values for your exam as well, normal values. What client teaching is completed prior to surgery for clients taking antiplatelet medications? Certainly you stop aspirin 7 to 10 days prior to surgery. Now, when I was, hang on just a minute. Let me tell my husband's downstairs blowing on his blower. Hang on just a minute. Let me tell him to please quit blowing on his blower. Sorry about that. Anyway, hopefully it's not disturbing anybody. So we talked about PT, PTT, INR, and I mentioned, why are you going to blow in the dark? Good Lord. Anyway, see what I have to live with. But anyway, you have to stop prior to surgery. I know. Good Lord. Some sort of disease process going on down there with the blower. Um, but anyway, and then so when I worked at the nursing home as the director of nursing, a lot of times, well, every 3 months, the dental people would come in in their little trailer, and we would take our residents out there to get extractions and Eliquis and apixaban and um, any other medication for coagulation, Coumadin for sure. They would all have to be stopped within certain windows. They were different too. Some were 48 hours, some were 72 hours. So you always have to um, check on that too. Indications for the use of thrombolytics, of course, a clot that's causing problems. All clots cause problems. Some cause bigger problems than others, um, like a PE, right? DBTs. Has anybody seen DBTs in the clinical setting to be familiar with what they look like? What does it look like? Professor Padilla knows. Red, swollen, hot. Absolutely. Good. Michelle, absolutely. Unilateral edema, for sure. Absolutely. Absolutely. It's swollen and kind of tight. The skin looks tight, and it is painful. It absolutely is painful. Very good. Very good. Contraindications, of course, to use of thrombolytics. Um, Bleeding, we talked about that. Um, Excluding menses, of course. Significant closed head trauma, facial trauma within 3 months, intracranial or spinal surgery within 2 months, uncontrolled hypertension as well. So why would that be? Why would um, uncontrolled hypertension be a contraindication? We kind of talked about it earlier when we talked about AFib. It's just because when your heart rate is and your blood pressure is exceptionally high, you have a very high threshold for developing clots. So you know what? I'm gonna dive into that a little deeper because I think I talked myself in a circle. But I'll get back with you on that one. I'm gonna check out the uncontrolled hypertension. But anyway, are thrombolytics contraindicated in pregnancy? Certainly, the risk of fetal and maternal bleeding would be a contraindication. So they're used with caution, uh, and there's really not a lot of valid studies on pregnant patients and thrombolytics. Adverse effects of thrombolytics, we talked about that: internal bleeding, bruising, damage to vessels, migration of blood clots to other areas of the body, certainly kidney damage, particularly in patients with diabetes and or pre-existing kidney issues as well. So dosing, of course, we talked about half-life. Um, Usually Lovenox is given like once a day. Coumadin is typically given in the evening around 5 o'clock. I don't really know the reason for that. Um, uh, uh, INR is followed regularly to make sure an appropriate dose is being given. It takes several days for the dose of or the doses of Coumadin to stabilize. So it's not something that is frequently changed or rapidly changed for sure, unless of course it's an emergent situation. Let's see, indications for the use of enoxaparin, of course, treatment of acute DVTs without PE, of course. Um, Sometimes it's given in conjunction with Coumadin. So if your patient's on Lovenox in the hospital and they're going to be transitioned to Coumadin at home, many times those two drugs are crossed uh, until the INR therapeutic range is reached. So it might be that your patient will go home on both, and certainly they may be given both in the hospital as well. So heparin-induced thrombocytopenia. I've actually seen that in practice. It happened to a woman who just delivered. It's very scary. Um, it actually occurs when the IgG antibodies bind to the heparin platelet factors to produce a very hypercoagulable state. It happens usually 5 to 15 days after beginning heparin therapy. It has a higher rate of incidence in women than men. Um, it's anywhere from 20 to 35% fatal. It's very scary. You have thrombocytopenia that will result in uncontrolled bleeding. Obstetric is a high population at risk, which is where I saw it happen. Um, when you receive heparin in the process of this of HIT developing, the uh, the patient receives heparin and then forms antibodies against the heparin. Yeah, absolutely. DIC too. DIC is something else that is formidable in the labor and delivery process. So some of the side effects, anybody know any of the side effects? You can imagine profound chest pain, shortness of breath, heart rate variability, like very erratic heart rate, and certainly profound anxiety as well. So some of the questions on your study guide are very repetitive. I did review all of the content of your module as well, and there are some really good little quizzes, so I hope that you'll take them in Module 4. Let's see. We talked about how do thrombolytics differ from anticoagulants. Anticoagulants obviously don't work on platelets. To break a clot, you need a thrombolytic like ataplase or streptokinase. Antiplatelets, like the name implies, prevents platelets from clumping. Um, and then, of course, anticoagulants inhibit clotting factors and stop the clotting cascade. Let's see. So then there are several dosage calc questions that we won't go over tonight. We certainly will offer uh, maybe at the next meeting. If you have questions or have issues working these dosage calculations questions out, please reach out to either Professor Padilla and we can go over them during class, or we can, certainly meet with anyone that's having some issues for sure. Let's see, indication for Coumadin or warfarin, prophylaxis for DVT, prophylaxis for PE, prophylaxis for any complications that could result from AFib, of course, and certainly valve replacements and the like. Onset of Coumadin, let's see, 24, 72 hours. Peak therapeutic effect is seen in 5 days after initiation of the therapy. However, the patient's INRs may increase within 36 to 72 hours after initiating treatment. So it's kind of a labile drug. And so for that reason, erratic, quick changes are definitely not made. We talked about heparin-induced thrombocytopenia and about the dismal prognosis. Let's see, unusual bleeding, of course, always needs to be reported to the healthcare provider. Abdominal stomach pain, backaches, unusual backaches, bleeding from the gums when brushing teeth, blood in the urine, coughing up blood, headaches, severe and continuing, heavy bleeding from cuts or wounds, something that nosebleed just won't stop, right? Pain in the joints, stiffness or swelling. What are benefits and risk to the use of rivaroxaban and or Xarelto? Let's see. Intracranial hemorrhage. Um, let's see. Risk of intracranial hemorrhage uh, um, uh, more so than with warfarin, but the risk of GI bleeding as well. The safety of efficacy compared to other anticoagulants for Xarelto is a little better. So remember, you watch out for intracranial hemorrhage and then certainly GI bleeding too, especially with Coumadin. Let's see, we're just about to wrap up this fun. I've been talking kind of nonstop. Does anybody have any questions? A lot of times these patients wear medic alert bracelets. So when they get to the hospital, they may be unconscious. The medical staff knows that they are on anticoagulants or Coumadin. In specific, safety measures, follow-up monitoring, of course. Take your medication, particularly Coumadin, the same time every day around 5 p.m. There are a lot of food-drug interactions with Coumadin. Does anybody know any of them? Leafy greens. There you go. Yep. Right. Absolutely. Absolutely. Vitamin K. Those leafy green vegetables have are a rich source of vitamin K. And a rule of thumb is to tell your patients, a lot of times people forget to take their Coumadin. So if they take it within 8 hours of the time they're supposed to take it, they're usually pretty good. But if they've missed for more than 8 hours, then they really need to have a repeat blood test to make sure that something is not going on and maybe their dose needs to be um, adjusted. Uh, there's a certain drug test called a D dimer, and it measures clotting or coagulability in the blood. So that's another blood test that that you will get to understand too. Of course, platelet counts, clotting time, D dimer will all give you kind of um, a good vantage point to determine coagulability of your patient. So medications to reverse heparin and warfarin. What reverses warfarin? We already talked about that. Vitamin K. And then what reverses heparin? Protamine, absolutely. And that's one of the things in the little quiz that's in Module 4. So we talked about, let's see, I think there's just a couple of more questions. Differences between heparin and enoxaparin or Lovenox. Heparin, of course, binds to antithrombin. It is, let's see, it can be given subcutaneously. It can also be given IV, which a lot of your, some of these dosage calculation questions will ask you to adjust heparin doses. So we'll get into that. Heparin, well, like I said, it can be given subcutaneous or intravenously. Lovenox is given subcutaneous only. It's more predictable. Certainly, it lasts longer than heparin. The effects last longer, and you don't have to monitor them, or you don't have to monitor clotting time. So, does anybody have any questions? I think that about wraps it up. This was relatively short study guide, but all the key information has been included. Professor Padilla, would you like to add anything? I'm sure I missed something. I get on a roll and just start talking fast.
Hey, good evening. No, thank you. I was muted the first portion of lecture, but it's It sounded to cover most of it. I think was there something I was going to mention? I'm looking over my notes, but no, I think you covered it all. I was looking to make sure that we had posted the heparin calculation stuff, and we did. I think the one thing that will get posted along with this evening's recording are some of the practice questions. And that's just an additional aid to kind of help you get into kind of that test taking mode so you have an idea as to what to expect, because we know that there's a lot of anxiety with the first exam because you guys aren't sure what to expect, how are the test questions going to be phrased, and that sort of thing. For the most part, it's everything that you come across in ATI. So we'll post some of those practice questions just so you guys can have that to refer to, and any other heparin calculation guides that we've got. Was there a question? Will you release the exam study guide next week? Are you talking about like the test outline, the blueprint? Yes. We can actually post that this week. We can post those ahead of time just to give you guys an idea of, where some of the content concentration is going to be. Yeah, absolutely. For the heparin docs and the announcement, it says I'm not allowed. That's interesting. Okay. I will try to get those reposted. Is anybody else having issues accessing it? In regards to dietary teaching, do we instruct patients to not change their diets or to limit leafy greens? Yes, to limit. Someone else was having
Absolutely.
okay. Yeah, well, I'll repost those attachments for you guys.
Thank you.
Yeah, thank you.
It's too cold out there. That's a really good question, uh, Paige, on behalf of Jasper. Um, I don't, I don't think it has much of an impact, but I don't know. And so that's a good question. Some of the information says, as far as the anticoagulants, um, they exclude menses, and so I'm not sure why they're excluded, but I can certainly ask. I know an OBGYN I could ask, but that's a really good question. And I don't know, Professor Padilla, I've never been asked that question of you, but it's time I learned the answer.
No, I'm trying to recall from my women's health experience. Um, I mean, in terms of like cycle, it doesn't necessarily affect the cycle. But I believe it does or can affect the bleeding itself and maybe increase in clots, but I know that's not like a solid answer. I'm not sure how in depth you guys wanted an answer.
So if you ever get to be an OBGYN, get back with us. I have a friend that actually was a nurse. No, that's really good, Jasper. That's curiosity is good. I have a friend who was in nursing school, and then after nursing school, she decided to go back and be a OBGYN. Yeah, very good questions. You guys are smart, smart.
Mhm. Going
Keep
back to the
us on our toes.
DVT, yeah, I was gonna say, and remember, DVTs can affect all ages. When I detected a DVT, it was when I was working pediatrics, and we had a patient who had been transferred from PICU because they had DKA, and they were hooked up to drips and whatnot, so they didn't have a lot of mobility, even though they were a young kiddo, right? And so when
Mhm.
we were doing our intake assessment from PICU, when I flexed her calf, she said it was sore, and so took a look. Sure enough, red, swollen. we did a Doppler and it came out positive for DVT. So it's not, something that affects just older adults or adults in general. So just kind of keep that in mind. Any other questions? All right. Well, thanks Dr. K, because she was running with most of lecture tonight. I just came in at the end. Tell you,
It's the
Austin
flamingo
traffic.
room.
Yeah, Austin traffic is not friendly anymore. It's picking up again. It's like back to normal, if not worse.
Oh yeah. I mean, I've heard it was worse. I really have heard, Professor Padilla, that it's just been tragic,
Yeah.
absolutely tragic. So anyway, yes, indeed, and thank you for everything for sure. So we have to have a prayer.
I have a prayer for stress.
Yay!
If
I
that
need it. I
helps.
need it. I need it. Pray
All right.
on.
Loving God, please grant us peace of mind and calm our troubled hearts. Our soul is like a turbulent sea. We can't seem to find balance, so we stumble and worry constantly. Give us the strength and clarity of mind to find our purpose and walk the path you've laid for us. In your name we pray. Amen.
Amen. Amen. Amen. All right, everyone. Look forward to more resources. Look forward to more cold weather. I'm not looking forward to it, just saying. But stay warm, be safe. Our prayers are with you always. Reach out if you need us. Indeed. Good night. Y'all have a good evening.